Please give a warm and silent welcome to this webinar host, Glenn. So, Glenn, can you hear us? Can you talk?
Yes, Alex, thank you for the introduction and setting up this webinar. And hopefully everyone can hear me. Can you hear me, Alex?
I can hear you perfectly.
Okay. All right, then I guess we're good to go. Okay, I will go ahead and get started. So yeah, I'm Glen Spielmans, and I am very honored to be here with you today. And you can see I'll be talking about psychotherapy trials and meta-analyses and some issues therein. So I'll just go ahead and dive in. That was supposed to go to the next slide. Let's try that again. There we go. Okay. So yeah, a little bit about me. I have been interested in systematic reviews of treatment efficacy in both psychopharmacology and psychotherapy, and have been, doing this kind of research for 12 plus years. And as I've become more interested in this, I've really become much more thorough, I think, in my outlook and in the way that I conduct and review this type of research. So, excuse me, I do have a little bit of a cough, which you'll get the treat of hearing throughout the presentation. Apologies in advance. But I've noticed that clinical trial results, both for psychotherapy and for psychopharmacology, are usually quite heterogeneous. They're really, it's hard to find a real exact effect. The effect sizes often are spread quite widely, and this often has something to do with the way the studies are designed, which kind of makes sense. We would expect the way we design studies would influence the results that we see. And I think as a result, I've certainly seen many systematic reviews that don't do a very good job of accounting for many of these variables, and I think that this can lead to misleading conclusions regarding the effects of different treatments. So I'm going to talk about some things we can do to try to avoid making those kind of mistakes. Okay, so what I'll do is give a super brief historical overview, and then I will talk about particular variables. You can refer to them as confounds or moderators. I think either one would be an accurate description. And then I will have some time for us to have some discussion, and I really look forward to that. I will describe a couple of examples of studies that have some confounds baked into them and how that may have influenced the results. These are, but two examples of many, many examples out there. And then I will give some specific recommendations, which should make sense in the context of everything I will have discussed up to that point regarding what clinical trials and meta-analyses should be doing. Okay, so I think we're probably all familiar with the idea of evidence-based treatments. And of course, there's been kind of an evolution of terminology regarding this. So, historically, this goes back a ways in clinical psychology. There was first the movement of empirically validated treatments in the 1990s, and that term kind of fell out of fashion, which was then replaced by empirically supported treatments, which has since been superseded by evidence-based treatments. And I have a feeling there'll be something that starts with an E and ends in T that will replace that as well, but who knows what that term will be. But of course, the general idea is that you have some sort of treatment that is shown to be effective. Of course, there are different ways to assess what that would mean. The most commonly used criteria in the clinical psychology world are those put forth by Chambliss and Holland in 1998, which essentially boil down to a treatment outperforming some kind of waitlist control group in 2 or more studies to a statistically significant degree. There's not really a consideration of whether the results are clinically significant. It's not clear what to do in the case of conflicting results. There are a few other issues with sort of aligning oneself with this, but in any case, this has been widely accepted in many areas. It's not necessarily a perfect way of evaluating treatments, but it has been emphasized a lot. So, excuse me. Also, what I'm particularly interested in the psychotherapy world is what happens when we compare different therapies to each other. I mean, I think it can be interesting to compare therapies to a wait list. I think the results are somewhat predictable. There aren't that many therapies that won't beat a wait list, so I think comparative psychotherapy trials are inherently more interesting. And of course, the idea is that if you compare two different types of therapy to each other, you might be able to discover which therapy is superior. And there's been many trials that have tried to establish which therapies are superior, and of course, there is some debate as to how to interpret those. But what I'll be really talking about is the design features of these studies that may lead to some problems. So theoretically, anyway, if a well-designed study shows that a psychotherapy outperforms a different therapy, then perhaps that therapy could become, quote, the gold standard for treating a particular condition. And of course, we would have to assume there being independent replication. We'd like there to be multiple research groups finding that a particular therapy outperforms another, which hasn't happened terribly often in psychotherapy research. And one issue that really needs to be considered, actually several issues, are how is this study done? The study methodology is quite important, and as I will provide some examples of, if you design a study in a way where one treatment is favored in a methodological sense, it might be higher dosage, it might be better trained therapists, it might be therapists who have an allegiance to one therapy as opposed to another, then one study may appear to be a, quote, winner. It may outperform the other therapy, but is that because the therapy is better or because the design favored that particular therapy? That's something we really need to consider. On a related note, I've really been interested in research that tries to transport evidence-based treatments into clinical practice and tries to assess whether evidence-based treatments are better than whatever clinicians are doing, which gets lumped into treatment as usual, which is an incredibly broad category of treatments. So the idea behind these studies, as you're probably familiar with, is that there's some research done initially finding that in an evidence-based treatment, well, it becomes an evidence-based treatment by outperforming a wait list in multiple studies. Then researchers get interested in, okay, well, if this treatment seems to be effective, why don't we move this into typical clinical settings and see if it works better than what clinicians are doing. I think it's an interesting idea. I will also say, having done meta-analyses in this area, there are some serious problems in the way these studies are usually designed. For instance, we often have no idea what actual treatment as usual is. And excuse me, sometimes treatment as usual isn't even a psychotherapy. So, well, more details on that to come. Okay, so I'm going to talk about some particular confounds / concerns / moderators. Pick the term you'd like to use. And so the ones that have a little asterisk by them, so like bona fide therapy, pre-training, these will get discussed in a separate slide. So I'm going to go into a little more detail on those. But otherwise, I'll discuss them here. So proximity to psychological intervention. So if we are comparing two therapies, then we should hope that both of them are actual therapies. So for instance, multisystemic therapy is a evidence-based treatment that's been studied quite a bit for treating delinquent youth, kids with conduct disorder, and it's been found to be better in some cases than comparison groups, better than treatment as usual in some studies. But treatment as usual in some of those studies is probation. In other words, being referred to the criminal justice system. And I don't think in any way, shape, or form that can be construed as a psychological intervention. So especially in treatment as usual studies, one has to examine whether treatment as usual was actually psychotherapy. So sometimes treatment as usual consists of a referral for treatment. So people are given either an evidence-based treatment the researchers are interested in, or a referral to seek treatment in the community. In many studies, it's not even clear if people follow up with the referral for treatment. So that's some examples on that particular variable. We'll talk about bona fide therapy and pre-training in separate slides momentarily. So supervision in clinical trials, sensibly, many researchers try to make sure that therapists are receiving supervision throughout the course of the therapy. So there's often like integrity checks to make sure that the study or the therapy is being delivered in a manner consistent with the treatment manual used in the study. And there's supervision that's given often on a weekly basis to therapists. But this amount of supervision is not necessarily equal between the psychotherapies being studied. So if one group is receiving regular supervision and another group of therapists providing a different therapy is not receiving supervision, that becomes a confounding variable that may explain differential treatment results between the groups. So that's one to look out for as well. The caseload of therapists. So what I refer to for this is sometimes there will be studies that one group of the psychotherapists in one group are advanced graduate students who are receiving regular supervision. And of course, they're busy people. We all remember our graduate school days. Perhaps some of you are living those days now. It's busy times. However, your clinical caseload is much less than a full-time clinician. So an advanced graduate student, therefore, would have much more time to prepare for each case, whereas clinicians in clinical practice typically have very little time to prepare for each case. So I think that is a potential confound as well. If one group has quite a bit of time to prepare in between sessions for each case, whereas therapists in the other group don't, I think that is a potential issue. Dosage, this one should be kind of a no-brainer, right? So we would assume that if we're going to compare two different therapies, they should be given at the same amount of dosage, the same number of, say, sessions and same number of hours. As I will describe, this is not always done. This is an issue that pops up with some frequency. Excuse me. And another variable, homework. So homework is valued by some forms of therapy more than others. So, this is a design feature of cognitive, most if not all cognitive behavioral therapies feature regular homework kind of baked into the therapy. And of course, this serves to make therapy relevant outside of the session. If, clients have to do psychotherapeutic work to complete their homework outside of the session, this maintains the relevance of the therapy throughout the week, which is wonderful. Whereas some schools of psychotherapy are not necessarily as big on giving homework, and that may explain differential results between treatments as well. Okay, so I'm going to talk about this bona fide therapy variable. This pops up in many psychotherapy analyses. I'd argue this should pop up in all psychotherapy meta-analyses as a potential variable. So when reading psychotherapy clinical trials that are comparing two therapies, sometimes it becomes clear that one or more of the therapies is not fully intended to be therapeutic. In other words, it's not bona fide. So sometimes the descriptions of these therapies make it pretty clear. So if something is described as a control for non-specific factors, so it gives you kind of the caricature of therapy. You have a nice, warm, empathic person who listens, assumedly nods their heads at appropriate times, and does reflective listening. That's nice. That's part of every therapy, right? That's why those are non-specific variables, but there's no theoretical orientation. There's nothing really guiding what's happening. It's just a therapist, essentially being told to act kind of like a therapist, but there's no active problem solving. There's no going through patterns that recur in what the client is talking about. So it's tends to be, this is kind of a psychological placebo as opposed to something that's intended to be a real therapy. And sometimes these are characterized specifically in study methodology as therapists being forbidden from doing various things. So you might have like a study comparing, say, cognitive behavioral therapy to what might be called supportive therapy. And the supportive therapy in many instances is not really a bona fide therapy. So it's described as perhaps therapists are not allowed to do anything cognitive. So they don't discuss the client's thinking patterns, not at all. They're specifically forbidden from doing so. They're also specifically forbidden from giving any advice on changing client behavior. So basically, this is defined as a non-cognitive, non-behavioral intervention. To make sure they're not doing anything, say, psychodynamic, they may also be forbidden from, describing how events from the past may have led to their present problems and so forth. So if you're reading, through the methods section of a study and there is a description of what a therapy is not, then it's quite likely that's not a bona fide therapy. The reference down below, Wampold et al. 1997 were the first to really kind of go through and thoughtfully describe how this might be coded. So what I have on here is not the exact coding scheme. You can find several meta-analyses that have used Wampold's criteria. You can use the original Wampold article as the source. I think it's a useful source for how you might code this specifically. Whereas, bona fide therapies have trained therapists, or at the very least, supervised graduate students. There's a theory that's clearly described that drives the intervention, and it's individualized. It's not like, say, pre-recorded applied relaxation instructions, that everybody gets the same thing. It's not tailored at all to their problems. Okay, so that's an important one to look at, and I will tell you that many psychotherapy meta-analyses don't consider this as a variable, and this can lead to some misleading results. Okay, pre-training. So this kind of gets at novelty effects. So and the term I like to use is a shiny new therapy. I think, we all, like new things. Maybe you get a new smartphone, you have a new car, new things. We like new things. People like new things, and we get excited about them. And I think that this applies in psychotherapy as well. So in studies, this is particularly relevant in studies that are training therapists and clinical practice to implement an evidence-based treatment. And so what happens is these therapists who are doing whatever therapy they're doing then get told, hey, there's this new evidence-based treatment we want you to learn about. They bring in expert trainers and they receive anywhere from a few to several dozen hours of training from experts who I would assume are charismatic and talented presenters. And this is probably going to get these therapists kind of fired up to do this new therapy. That's going to make them excited. And the reason I call this a novelty effect or a shiny new therapy is, I think after a period of time, oftentimes after we play with new things, they become somewhat less interesting. The newness wears off, if you will. And so I think that this is basically studies that get people right after this pre-training that have people all fired up to go out and give the new therapy are catching therapists when they might be the most enthusiastic. And I think it would be interesting to examine those same therapists, 4 years down the road, do they still have the same level of enthusiasm for that new therapy? Okay, a few other things. Patient preferences are rarely accounted for in clinical trials. So there is plenty of good evidence to suggest that if patients receive treatments in alignment with their preferences, preferred form of therapy, or do they get medication when they would prefer psychotherapy or vice versa, these things tend to impact outcomes. So oftentimes, there may be random assignment to one form of treatment or another, but it's not reported whether clients got the treatment they wanted. And I think that's a useful thing to think about. Researcher allegiance has been found over meta-analytic reviews in several different areas of psychotherapy to be a very good predictor of outcomes. I don't think this is necessarily researchers doing anything nefarious. I just think that this, if you're a researcher, you have a treatment that you really like, that you're developing, you're going to do your best to make sure that treatment is implemented in a very solid manner by very well-trained therapists receiving excellent supervision. And the group to which your preferred therapy is being compared is probably not going to be delivered with as much gusto and enthusiasm. So I think that researcher allegiance is something, something well worth accounting for. In psychopharmacology research, sponsor bias, serves a similar role where, drugs that are tested by the manufacturers tend to show superior results. There are, in many cases, more nefarious explanations for that, but that's for a different day. We'll talk about that. We'll talk about therapist allegiance here in a minute. Therapist effects. So obviously, this is pretty easy to model in a clinical trial statistical analysis. How do results vary across therapists? That's rarely reported in clinical trials. I would say things have gotten better in this regard, but they are still often unreported. So, obviously, therapy is delivered by therapists, and therapists tend to have a wide distribution of outcomes. Some therapists are pretty good at what they do, and other therapists don't tend to generate very successful outcomes on a consistent basis. So it makes sense, if we're comparing two therapies that are delivered by different therapists, that if one form of therapy is superior, is that because the therapy was superior, or because the therapists delivering the therapy were just better therapists? That's something that should be examined. And we'll talk a little more about particular outcomes here in a minute. We're coming up on discussion time too. If you're interested in asking questions, we're getting close. So therapist allegiance, I think this is a really important variable that is so often overlooked. So, non-bona fide therapies in studies are delivered by therapists, which of course is an obvious statement, but what sometimes I think people miss is that means these non-bona fide therapies are not valid treatments. So if you're a therapist and you're delivering a therapy that isn't supposed to work, it's a placebo, there's no theoretical guidance for it, you don't really believe in the therapy, then how can that therapy achieve maximal outcomes? If a therapist is knowingly delivering a placebo, how does this generalize to clinical practice at all? I would hope that it doesn't. I can't imagine there are very many clinical practitioners who knowingly show up and say, I'm going to treat my clients today with placebo. I don't think it's going to work. I'm going to, make sure I do this thing that I don't believe in. That doesn't really, make sense. But this is done in research all the time when we have comparison groups that supposedly control for nonspecific factors, but they really don't, because one very important nonspecific variable or nonspecific factor in therapy is that the therapist believes in what they are doing. And a non-bona fide therapy really kind of takes that out of the equation. So of course, in comparative trials, all therapies should be delivered by therapists who really believe in them. And of course, for placebo therapy, it's going to be difficult to do that conceptually. You won't find too many therapists who show up wanting to deliver a therapy that they don't think will work. All right, I'll briefly talk about the Cochrane risk of bias tools. I'll mostly refer you to Munder and Barth for a really excellent discussion of these in more detail. These have been more widely included in psychotherapy meta-analyses, actually more than some of the variables I've talked about previously. So these are an attempt to examine issues that might affect internal validity or biases in clinical trials of medication. So the Cochrane collaboration, or they took out the term collaboration, they're now just Cochrane, and they wanted to assess internal validity using a variety of tools. So here are some of them briefly. So sequence generation. So were randomization procedures adequate in a study? That's relatively self-explanatory. The second one were the randomization procedures conducted in a way that the study personnel couldn't have impacted the results of the randomization procedures. I think the third one is really important. So blinding of outcome assessments, I think this may also play into researcher allegiance effects. So if let's say that you are a firm believer in a psychotherapy you are testing in a study, you're a researcher with allegiance to a particular therapy. If you or your subordinates in the study are aware of which treatments people are receiving, and you're then doing the clinical ratings, you can see how bias could very easily creep into that. So it really is asking very little to have blinded clinical raters to eliminate potential bias there. Okay, as a meta-analyst, here comes one of my pet peeves, which is selective outcome reporting. So, I'm trying to extract data to generate effect sizes for a meta-analysis, and I will run across variables that are simply reported as not significant. No specific p-value, no means, no standard deviations, and I think to myself, this isn't even meeting basic data reporting requirements that all journals kind of subscribe to. So that drives me a little crazy. It's very hard to account for, data that don't, not significant could mean a lot of different things. So this is something that should be considered. And as a meta-analyst becomes kind of complicated to handle, especially if you have lots of selectively reported data. That suggests there might be some bias in the way the data were entered or the way the data were reported, and you sort of perpetuate that bias if you only then report the data that are in the journal articles. Incomplete outcome data, this can also be complicated because in psychotherapy studies, we often have dropouts. In fact, we almost universally have a mild, somewhere between a mild and high degree of dropout in studies. So there are many ways to handle missing data, and that, I mean, frankly, that could be like an entire different webinar, so I'm not going to attempt to get into that in detail. But this is something that needs to be considered. For instance, if you only are including data on people who completed studies, then you're looking, of course, the best responders. People typically drop out if things are not going well in a study. So the last variable, basically has to do with like adherence checks, integrity checks. Was treatment in each group implemented in a consistent way? Okay. Other considerations, and let me check. Yes, then I'll open it up for questions and discussion. So I think external validity is sometimes overlooked. So looking at demographic variables and how well things generalize can be important. Many clinical trials exclude patients with substantial comorbidity, which really limits generalizability to real life patients who often have a substantial amount of comorbid psychological distress. So that's important to consider. Psychotherapy orientation. This is really interesting because I'll even say myself, I didn't give this as much thought as I should have for quite some time. The good news is I'm in good company. A lot of people haven't really attended to this as much as they could have. So it's unclear what constitutes a brand of therapy. So, I would imagine everybody who's listening to this presentation has their own idea of what cognitive therapy looks like, what behavioral therapy looks like, what cognitive behavioral therapy looks like, or what interpersonal therapy looks like, etc. The thing is that your definition may not match another person's definition. And so, especially in like a meta-analysis, as people are putting together studies that supposedly give a verdict on how effective is cognitive behavioral therapy versus other therapies, for instance. Well, what counts as cognitive behavioral therapy becomes really important then. So different meta-analyses have differed as to whether eye movement desensitization reprocessing, EMDR, is that a form of CBT? You will get differing answers, and that may influence the results of systematic reviews. What counts as interpersonal therapy? Even cognitive behavioral therapy, Wampold has done some, Wampold and Bardseth and others have done some interesting research into how one defines CBT really influences what the results of systematic reviews of CBT are. So this is a overlooked but a very important topic. And so now as a peer reviewer, I'm just a real pain in insisting people do a really good job of considering this. So outcomes typically, like symptom severity ratings have often been kind of the gold standard, but I would argue that that's kind of a fool's gold standard. There's really no reason that those outcomes are necessarily more important, kind of depending on the condition. I would argue that one's quality of life is important. So if your symptom severity ratings show a substantial increase, but your quality of life has not really changed, I think that's an important consideration. How well are you doing in life? How about your work, your relationships, for students, your academic functioning? These things should be considered. As time has gone on, clinical trials have gotten better about including these measures, but there's still a long way to go. Also, adapting from medicine, some clinical trials of in the area of clinical psychology have adapted primary outcomes. Really, primary outcome is only there to prevent someone from cheating in a study. So the origin of primary outcome is that in drug trials, the sponsor must declare a priori what the primary outcome is. So they say this is the most important outcome to prevent them from post hoc claiming that whatever was significant was the primary outcome. So when you see the term primary outcome, that's just an attempt to prevent cheating. It doesn't necessarily mean that the primary outcome is any more important than what are described as secondary outcomes. Okay, I'm done talking for a minute. I would be happy to respond to questions or comments.
Okay, so anyone who'd like to ask something to Glenn can either do it on the questions tab, and I'll read out all your question. And we have actually a hand raised, and let's see if it's on purpose, from Branislava. I hope I'm saying the name right. I'm gonna unmute the microphone and see if we can get a question here. Let me see. Branislav, I can't really hear you. I don't know if you have a microphone, but if you have a question, could you please write it on the questions tab? And anyone else who would like to do so, just give it a few seconds. We have a question here. So I'll read out all the question, Glenn.
Okay.
We often think about the quality of the rationale provided to clients for treatment, but your point about therapist allegiance and non-bona fide treatment makes me wonder if we might need to be reporting and assessing the rationales provided to the therapist as well.
I like that question. That seems like a very reasonable idea, and I can't. Boy, I'm sure at some point some study has done that, but one doesn't pop to mind. So I think that is, often one sort of reads between the lines. And I think, in cases where, the researchers clearly kind of have an allegiance to one form of therapy, I think one can read between the lines accurately and assume that, they provided a rationale that, this is going to be a pretty good therapy. But then whatever sort of non-preferred perhaps by the researchers, therapy, it would be really interesting to know what the exact procedures were in terms of recruiting therapists, describing this particular form of treatment to the therapist. I think that is a very good point.
I think that's all the questions we have for now, so I think you can continue, Glenn.
Okay, so I will move on, and I've got some examples of studies that didn't control for some of the variables I talked about earlier. And I mean, before I go on, so I realize that my research involves evaluating other people's research, and that can seem a little bit snooty. And I don't mean to talk ill of researchers. As people, I'm making no personal attacks here. I simply think there are some issues in study methodology that can lead to misleading results, and so that's all I'm talking about here. So we'll move on to discuss a study published in 2000, CBT versus non-directive or supportive therapy for social phobia. So cognitive behavioral therapy, 20 total hours of treatments, a nice, plentiful dose treatments. So 8 1-hour individual cognitive therapy sessions, 6 2-hour group social skills training sessions. So pretty comprehensive. Meanwhile, the comparison group, non-directive or supportive therapy, 3 hours of treatment delivered across 6 30-minute individual sessions was the comparison. And I think right off the bat, you don't have to be super good at math to see that that is a pretty gigantic difference in terms of treatment time. Now, the authors noted that this was a limitation in their discussion that was noted in the abstract. So, to their credit, they noted that this was a pretty substantial limitation. However, when meta-analysts or systematic reviewers, pick up on this study later on, if they don't account for this difference in dosage, this huge difference in dosage, then this becomes a problem. So there's more here. In the same study, CBT therapists had a prior background in CBT, and they had 18 specific hours of training given before this study in terms of implementing the study protocol. Meanwhile, the supportive therapy therapists had a background in either CBT or psychodynamic therapy and had 1 6-hour supportive therapy training. So yes, both groups had training. One group had more training, and the CBT therapists also happen to have a background in that particular form of therapy. So I think we've got another confound kind of built into the study as well. So in the results, this probably shouldn't surprise you. CBT was more effective across the board. So again, the authors noted these limitations. You didn't have to read real hard in the article to notice that they pointed out these limitations. But again, later meta-analyses I got to tell you, a lot of systematic reviews are not very systematic. You know, there should be some criteria where maybe we can call something a non-systematic review, which doesn't account for things as basic as this dosage difference. You know, if a later meta-analysis, and it's not an if, this is a real thing, later meta-analyses then take this study and use it as evidence to show that CBT is superior to non-CBT, this study is so confounded that you can't possibly reach that conclusion. All right, so the next one is dialectical behavior therapy versus community treatment by experts for borderline personality disorder. So this was done by Linehan and colleagues. So you'll note right off the bat that there's going to be some, researcher allegiance, right? Since Linehan is the designer of dialectical behavior therapy. So the study claimed to maximize internal validity. You can see that's a quote from the article, by using community treatment by what they called experts as the comparison group. So as opposed to, having therapists who may not, have expertise in treating difficult clients, they found what they termed to be experts in treating difficult clients. But it turns out there are some problems here, I would argue. So on the results, DBT outperformed community treatment by experts on most outcomes, but there are some things to think about. So therapist training, DBT therapists had, a lot of training, which, is to DBT's credit, they make sure their therapists are well trained. I don't really have a problem with this. 45 hours of specific training, several supervised DBT sessions prior to the study. So they're making sure these therapists know what they're doing. And half of the therapists also had some prior exposure to DBT. So that's fine. However, the comparison group, these were people who were, quote, nominated by community mental health leaders and were, quote, considered experts in treating difficult clients. At first read, this doesn't sound so bad, and maybe it's not, but I do have some concerns. So A, there's no pre-training provided. So the DBT therapists got a lot of training. We talked about before this pre-training, if it's provided to one group and not another, can be a confounding variable. And I would say this is a pretty good training the DBT therapist got, and was not given likewise to community treatment by expert therapists. In addition, although it says they were experts in treating difficult clients, that does not necessarily mean expert in treating borderline personality disorder clients. So I don't think those two things necessarily map onto each other perfectly. So I think, and again, they were nominated because they were considered experts in treating difficult clients. In my mind, I don't know exactly what that looks like. I don't, if somebody is considered an expert, I don't know if that means they really are an expert. There's lots of research. If you're familiar, the exact citations will escape me at this point, but looking at people who are considered experts who show up on cable news programs and they're considered experts, there's research that looks at their ability to predict future events. It's not very good. My point is that sometimes people that are considered experts may or may not actually be experts. Okay. It's a long-winded explanation, sorry. So supervision. With DBT, you have weekly supervision that's built into DBT. That's one of the strengths of the DBT model. So let me be really clear. I've got nothing against DBT. I think it's a really well thought out, excellent intervention. My problem is with the way the study was designed. So those are two different things. You can still like DBT, but not necessarily be a fan of how a DBT study was designed. Okay. So community treatment by experts, I thought this was quite interesting. They had optional weekly consultation at the Seattle Psychoanalytic Institute, and the authors mentioned that this was a prestigious institute. It might be, I don't know. But my main concern is that as prestigious as this might be, what is the relevance of consultation at a psychoanalytic institute if you are not psychoanalytic in your orientation? It was not clear that these community expert therapists were actually psychoanalytic in their orientation. So I'm not sure that this particular form of supervision was terribly relevant for them. In addition, it was reported that greater than 40% of the clients of these so-called community expert therapists had therapists who received no consultation, no supervision throughout the study. So there's another variable favoring DBT in this study. So the dosage, DBT, has about 3.5 hours a week of treatment, which again is a strength of DBT. I like that it takes clients in severe distress with borderline personality disorder, and instead of doing an hour a week of therapy, which frankly isn't enough for clients with such complex needs, so you've got a high dose therapy, which unsurprisingly had greater dosage than community treatment by experts in terms of the number of individual and group sessions. This is a problem, I think, because then community treatment by experts has more inpatient and day treatment. The authors didn't note this, but I think a completely logical hypothesis here is that perhaps the lower dose of individual and group treatment for the expert therapist group led these clients to require more inpatient treatment because they simply weren't getting the outpatient treatment they needed throughout the study. So although this study was touted by the authors as doing a really nice job of controlling for threats to internal validity, I suppose I differ in the interpretation, and I think this does not necessarily demonstrate that DBT is better than a well thought out intervention, because I don't think this community treatment by experts was as well thought out as it could have been. All right. I'm open to taking questions or comments at this point regarding these studies, or really anything I've talked about or related issues at this point.
Thank you. That's really fascinating, Glenn. And I'm again going to hand over the mic to whomever would like to ask any question, or if they would like to write a question on the questions tab. It is true that we'll also have a chance at the end to have a larger reflection and discussion, but if anyone has any question right now, you can put your hand up or write a question in the questions tab. Just give it 2 seconds. I think everyone is immersed in what you're saying, Glenn.
Okay.
In that sense.
Hey, this feels like teaching class. When people are silent, let's assume they're immersed, but they might be asleep. We'll find out which, perhaps later.
I can tell you I'm in the first category, so
okay. Well, it's good to know one person's in. Okay, so I will move on to discussing my recommendations. So first of all, I got into really kind of reading meta-analyses as a grad student when meta-analysis was.
I'm so sorry to interrupt you, but we actually have a hand raised.
Oh, great!
Who rose?
Super.
Let me see if I can get here. Hi, Kim. Can you talk?
Yes, I can.
Okay.
Can you hear me?
Yes.
Yes, I can.
Oh, great. I realize that maybe now you're going to give the answer to that question now that you're talking about recommendations, but the issues that you mentioned in sort of differences within studies, I can imagine that those kind of differences really differ to a great degree between studies. So if you then do meta-analysis, how could you account for these kind of issues? But maybe that's what you're going to talk about right now, right?
Yes, I actually plan to get into that. So here's let's make an agreement. I will talk about this, and if I don't address it adequately, I want you to re-ask the question, and I will go into more detail. Does that work?
Sure.
Okay, thank you.
All right.
Okay.
Okay, thanks for the question. And so I will try to address that. What can we do as meta-analysts to try to account for this kind of thing? And I hope I do an adequate job of that. So I got really interested in meta-analysis, kind of reading about it, and in really the mid-1990s, when frankly a lot of the meta-analyses, if you look at the meta-analyses then compared to now, statistically there, and sort of the way they were done was not as impressive as what people do now. Is a little bit younger, but it was nonetheless pretty interesting. And I noticed that people ascribed a lot of status to meta-analysis. So I think people often have the conception that meta-analysis is like a higher form of evidence, or this makes me shudder, the final word on a topic is found when putting together studies. And although I do meta-analysis and I like people to like my work, I really don't think that meta-analysis necessarily is as good as people have given it credit for. So certainly it can be more comprehensive. You obviously have more statistical power and precision when you're pooling the results of many studies together. It's going to give you more precision than any one study. That's all fine. However, a meta-analysis that doesn't carefully control for potential issues in the internal validity of the studies is not a higher form of analysis, it's a problem. So I think there are a lot of things that need to be considered. I will say that I think meta-analyses in psychotherapy are generally more thoughtfully done than they are in psychopharmacology, where I also have done some meta-analytic work. And there's a guy named Tom Jefferson, Dr. Tom Jefferson. He does some work. He I think is an associate editor with the British Medical Journal. He's done some work with the Cochrane Group, and his argument at this point, I don't think I'm as cynical as Tom is, but some days I might be, that meta-analysis that relies on results published in journals, at least in the area of medical clinical trials, is kind of garbage in, garbage out, because there is so much unpublished data. And hopefully, I'll touch on this a little bit. We'd like to think that in the world of psychotherapy trials that there is there's less of an incentive for people to not fully report their data, that we assume that what's in the journal are, the data are reported accurately and fully. And as we'll talk about, the results are kind of mixed on that. So I think it's a little better than what's going on in the clinical trial world in medicine, but sadly, it's really hard to know in a published journal article of psychotherapy where all the results reported. It's kind of an honor system. So pardon my cynicism. I think I've been doing too much research in psychopharmacology, and it's made me a little biased. Anyway, so let me get a little more specific here. Things that you can do, and this gets to the question that was asked a couple minutes ago. You really, as a meta-analyst in the area of psychotherapy, need to have coders go through and look at these variables that I was talking about. Depending on the amount of time and which particular issues you suspect may be of concern, you may not choose to code all the variables that I have listed. I understand that that is a very tall order. It takes a lot of time to do it. So you need to have multiple raters on board. You can't just have one person going and coding variables, because, every person is bound to make some kind of mistake in their coding. So having multiple eyes independently coding and then checking their coding can help to assess. So I would, for example, I would think coding, if we're comparing, if we're doing a comparative psychotherapy meta-analysis where we're comparing different forms of psychotherapy, you have to code whether psychotherapy was bona fide or not. You can't lump together bona fide and non-bona fide therapies as if they are the same thing. That doesn't conceptually make any sense. So I'd say that's one, you really would be important to code. There are several other variables I've talked about before that I would also recommend coding, with the understanding that each variable that you code is going to take, a fair amount of time to do. So like researcher allegiance, this is one I should have talked about in more detail earlier, but researcher allegiance can be coded in a few different ways. So the easiest way to do it is to, kind of look at the treatment manual that is provided and see, did any of the authors develop the treatment manual? If so, then obviously there's researcher allegiance. So that's an easy dichotomous yes or no kind of way to code it. There was, I should have put this in my references, but I think Gaffan, Gaffan, developed a coding scheme that was published, I want to say in 1995. I think it was in the Journal of Consulting and Clinical Psychology. that was a more formal scheme that looked at things like how the published journal article in the introduction section, kind of the way that it discussed prior research on therapy. So if it seemed to have a very favorable view in the way they discuss, say, cognitive therapy in the background, you might assume that the researchers have some allegiance to that therapy. It's a little more complicated than simply coding yes or no based on did the researchers develop this particular treatment used in the study. It's more complicated to use, but I've seen it used, it implemented successfully. Also, when you're coding variables, the methods section of your meta-analysis should really clearly report how you coded things. So, for instance, if you're doing a meta-analysis on cognitive behavioral therapy, please report what counted as cognitive behavioral therapy. What did the therapies have to do to be cognitive behavioral? So there can be differences. You might have coded something as cognitive behavioral only if it used both cognitive and behavioral interventions, if it only if the methods of the study explicitly stated the use of both cognitive and behavioral interventions. So for instance, pure cognitive therapy would not count as CBT in your analysis. Pure behavioral therapy would not count as CBT in your analysis. So these are decisions researchers can make. You know, I don't know if there's a real right or wrong way to code cognitive behavioral therapy, but I do know that it should be very clear what cognitive behavioral therapy means in any particular meta-analysis. So carefully coding moderators takes a lot of time. It's, you know, sometimes there are variables that are quite easy to code. Sometimes it takes some real time to think about it. Whether therapy is bona fide sometimes is pretty clear. Sometimes it does take some additional thinking. Sometimes you need to look up references that appear in a clinical trial to give you a better idea as to whether what they were doing was bona fide. So there's kind of a paper trail that you need to go through. So coding moderators, having done, you know, coding moderators for the last, oh boy, 13, 14 years, it takes a lot of time. And, you know, I'm someone who's coded a lot of these a lot of times, and it still takes me some time to really thoughtfully go through and code them. So you need to plan accordingly. These meta-analyses, like the way I'm recommending to do a meta-analysis, will take much more time than doing a, quote, quick and dirty meta-analysis, which unfortunately there are many of that don't consider any of these moderators. So, you know, if you could do a meta-analysis on a psychotherapy in a relatively short amount of time, if all you do is extract effect sizes and plug and chug your analyses, whereas if you're going to thoughtfully go through and consider how various moderators or confounds might influence outcomes, this is going to take you a lot longer to code. In your analysis, you're going to have to try to account for these different variables. That's going to make your analysis take longer. But I would argue you'd have a much, much empirically stronger product as an end result. So if you're looking for a lot of publications, I would instead say, think in terms of quality as opposed to quantity. So moderators, you know, tend to explain a lot of the widespread of individual study effects. So, you know, you'll find a wide variety of effect sizes. Typically in a meta-analysis of mental health interventions, you will find that the results are spread more widely than you would expect in a normal distribution. In other words, the results are statistically heterogeneous. And the moderators may explain part of why these results are spread so widely. So here are just a few examples. My team did a research of evidence-based treatments for youth. That was when these were compared with treatment as usual. Evidence-based treatment for youth was only more effective than treatment as usual when researchers had allegiance to the evidence-based treatment, which I thought was an interesting finding. Another meta-analysis of evidence-based treatment for youth relative to treatment as usual, they used threshold for diagnosis. In other words, did clients meet the threshold for a DSM diagnosis, or was their pathology less than what was required for such a diagnosis? They found evidence-based treatments for youth only outperformed treatment as usual when problems did not reach the threshold for a DSM diagnosis, which again, I think is pretty interesting. Wampold, digging back a little bit in time, did a nice meta-analysis that found that so basically they were looking at a prior meta-analysis that found that cognitive behavioral therapy, they claim, and I think this is a 1998 meta-analysis by, I'm going to mispronounce the name, Glen, something like that. I apologize for the mispronunciation. Anyway, Wampold and colleagues noted that when CBT was compared to other therapies, it was not clear whether the other therapies were bona fide or placebo therapies. So they went through and coded these so-called other therapies into bona fide versus not. What they found was that when you compare CBT to non-bona fide therapies, in other words, placebo therapies, indeed CBT is superior. However, when CBT was compared to bona fide, fully intended to be therapeutic therapies, it did not outperform them in the case of depression. Later meta-analytic work has also been pretty good in supporting that there are a lot of therapies for depression that seem to have very close to equivalent efficacy. Let me see here. Okay, sorry. I'm gonna. There's one point I didn't put on this that I didn't put on here because I think I was trying to make sure to not take too much time. So I'll quickly go through this. Oftentimes, what's tricky is you will have moderators confounded with each other. So you may have. So let's say you have supervision is one of your variables. Did both groups get equal supervision? Dosage was dosage equal between groups or not? And whether therapy was bona fide. Well, there will be overlap between those. So some studies in which treatment A was compared to treatment B was not bona fide. In some of those, the dosage was unequal. In some of those, supervision was not equal. So really, it's a matter of what I try to do is try to then narrow down to how many studies controlled for all of the confounds that I had in mind for the meta-analysis. And you may start off with 60 studies, and there may only be 10 that were a reasonably fair comparison of bona fide treatments of different theoretical orientations. So it becomes, I'll say that in clinical trials, and this will lead into my next slide here, a lot of these variables are not controlled for, and it's not uncommon for at least one of them to not be controlled for in a clinical trial, making it really difficult to know if a therapy that shows better results was due to truly superior therapy or due to some other confound. So clinical trials, really, we're in the day and age where I no longer want to hear from an editor or an author that there wasn't enough space in the journal to print the study methods in detail. That doesn't cut it. There are online supplements. Any journal can simply choose to post information online. If they're too cheap to host it, the author can find a place to host it. Online storage is cheap. So there should be detailed description of study methods. I will tell you, as someone who reviews meta-analyses often, this drives me batty to see how often things are reported in very little depth, and in clinical trials, ditto. So there really needs to be a good, clear description of what went on in a study, and this allows meta-analyses, if they choose to be truly systematic, to go through and code for these variables later on. Now, again, it's good to control for as many potential confounds as possible, but the understanding is, as you control for more and more of them, this takes more and more of your time to do. You may end up, if you limit it down to only the studies that have no potential confounds, having a very small sample size, but that's how it is. Data should be reported in clinical trials clearly. You're all familiar with this. You should know how many participants were in each analysis. You'd be surprised how often this isn't clear. Clear results, you guys are familiar with mean standard deviations, p-values, et cetera. Very few psychotherapy clinical trials are pre-registered. And the reason this is important is, I'll tell you that in the clinical trial world, I've talked about this before, of clinical trials of medicines, quite often people will switch around outcomes or they won't report data fully. I'm doing a meta-analysis now where I've noticed at least 2 of the trials that are included have not fully reported data. So at least in the world of medicine, sometimes there's data on hand with regulators such as the Food and Drug Administration or the European Medicines Association or Agency, European Medicines Agency, that's, they will have data on file you can compare published results in journals to, whereas for psychotherapy, there is no regulatory agency. So you kind of have to take what's published in journals as being fully accurate, whereas in some cases, it's clear that's not true. It'd be nice if clinical trials could report data, without putting a spin on it, just report data accurately, without unnecessarily editorializing in favor of one therapy over another, especially if the data don't support it. Meta-analyses can be misleading. So failing to account for these variables, this is kind of a review at this point. You can get false winners and losers if you don't account for things like whether therapies were bona fide. I think, yeah, the first kind of bullet point up here, this is all kind of review. Yeah, considering multiple outcomes, I mentioned it earlier, I think it's important to mention again that we don't really have any goal. Sorry, I shouldn't say we don't have any, but and for the vast majority of psychological conditions, we don't really have a gold standard measure that is clearly more important than others. I can, perhaps in like a specific phobia, I can see how a behavioral measure of, if somebody came into therapy with arachnophobia and they can leave therapy holding a spider in their hand comfortably, I would say that's a pretty darn good outcome measure. That's fine. But most psychological problems don't lend themselves to such clear-cut measurements. So I think a wide variety of measures, measuring, things like quality of life, functioning, symptom severity, when possible, having multiple raters. I think all these things are good to keep in mind. And this Bradley study that is including your references goes into a little more detail about there being some publication bias in psychotherapy, which again is sort of harder to look for, but they found some clinical trial protocols saying what was going to happen in some studies of psychotherapy, and they found that those didn't always match the published results. So that's the reason I've sort of mentioned this as a concern. Okay, I'm done talking, at least until you ask me some questions. So what questions do you have? And this can be, we can kind of consider this like the final stopping point for me. So questions about anything, I am happy to take them at this point.
Thank you so much, Glenn. So let me again invite anyone to talk. We have a hand risen here by Susan, so I'll try to pass the microphone to Susan LG. Susan, can you talk?
Yes, can you hear me?
Yes, we can hear
Yes.
you. Great. Something that's interesting that I don't think you've mentioned is differential effects of treatment. So if a treatment works for girls but not for boys, or for differently for people of different ethnic groups, how would you treat that in your work, or what recommendations do you have?
Sure. Okay, so you mentioned differential effects by gender and different ethnicity, I believe. So yeah, I think these are questions that are typically less examined in psychotherapy clinical trials. So you may have more knowledge than me on this, but I know, for instance, like there's some evidence suggesting that like culturally adapted therapies work better than those that are not. So in other words, if you take a psychotherapy and you adapt it to the culture of the participants receiving the therapy, that seems to result in at least mildly to moderately better outcomes. So, that's in terms of ethnicity, I think of cultural adaptation as opposed to specific ethnic groups, because I'm not, again, you can tell me if you're thinking of something specific, but I'm having a hard time thinking of like psychotherapy that has been demonstrated to work in general better with ethnic group A than with ethnic group B. I think that's not necessarily because it doesn't occur. I just think that's something that often isn't analyzed. The data are not necessarily reported, or it will be reported as my least favorite. Results were not significant, right? So we did an examination of across ethnicity, it was not significant, and then it kind of that's the end of that issue. And same with gender. I think I've seen discussion on occasion about more questioning, I suppose, whether particular therapy works better for one gender than another. But I'm not terribly familiar with outcome results showing that there is a gender by therapy interaction. But I'd be interested in your comments too.
My background's in education, and of course, you see it all the time in education.
Okay.
I was just wondering, like, how meta-analytic scholars deal with the issue, but if it's not an issue in psychotherapy that's examined, then this isn't the wrong place to ask the question.
No, I mean, I don't think it's the wrong place to ask the question. I mean, I think, if we're talking about, research that's, I think if somebody were particularly motivated, they could go through clinical trials and they could examine, the gender variable, whatever is reported regarding gender. There might be, a T-test or an F-test examining gender, and then, one could try to pool those across studies. I would imagine you would have a pretty small sample size.
And me too.
So I think that this is kind of interesting avenue for future research, but I don't think that what's out there now would be totally fruitful, but it would be interesting for somebody to do the legwork and find out.
Thank you.
Thank you.
So we have a couple more questions. I'm going to pass the microphone here to Kim de Jong again. Kim, let me see if I can give her the microphone here. Kim, can you talk?
Yes.
Yes, we can hear you.
I actually have two questions, but I also want to give other people a chance to talk. So shall I just ask one, and then if we have time left, you can unmute me again for the other?
Mm-hmm.
Okay. So I was wondering, when you have to decide in your meta-analysis sort of how inclusive you're going to be, would you say be more strict and only include more higher quality studies, or would you say, okay, if you code the potential biases, then include everything and just run moderation analysis?
That is a great question. So I think I think a lot of this kind of boils down to what you consider to be indicators of quality. So for instance, what I've seen, and I don't favor this approach, is people who will take like a rating scale. The JDAD, JADAD is a scale that was developed for medical research, for instance. And they'll say, well, if it scores above a certain threshold, then we'll include it. If it scores below that threshold, we won't include it. I think general indices of methodological quality are problematic because I think each individual variable is something that should be considered separately. So, I think, maybe most meta-analyses, and I can understand why they do this, kind of require like random assignment to groups, for instance. I think that's reasonable. I think if you get into non-randomized studies, you may develop some serious problems. But on the other hand, I don't see there being a problem if you choose to include non-randomized studies, provided that you code for that, and then you could include it in moderator analyses. I don't think that is necessarily a problem as long as you're trying to account for, what's going on in the studies.
Okay, thank you.
Mm-hmm.
So we have two questions here, and I'm going to read them, and then I can pass the microphone back to Kim. So the first question to read here is, how do you think qualitative methods of researching psychotherapy process and outcome can contribute, even as remedies for these limitations or problematic situations in RCTs?
That's a good question. I'm probably not the best person in the world to answer it, in the sense that I've done some qualitative work, but it's not been on process and outcomes. So I'm more kind of like I'd count myself as an occasional reader of qualitative process outcome research as opposed to an expert on it. I would definitely not label myself as an expert on that, but I can see how, one could, and I do think qualitative research in general often gets overlooked. If you when it comes to evaluating psychotherapy efficacy, the discussion typically is, quantitative, meta-analysis, and considering all the meta-analysis we've done, there's still so much to be learned that probably can't be answered through meta-analysis. So, I do think the process outcome research is a niche that's going to yield results that certainly couldn't be uncovered by quantitative meta-analyses. I know that's a pretty general answer. That's about as good of one as I can give.
I have here another question here in the tab, and I'm going to read it out loud. Eva actually replies to what you just said. That's okay, thank you.
Okay.
But another thing here is, I'm going to read it. These published studies passed peer review. we have read studies that we think, how did it get away with that? Is this a systemic problem in our field? Perhaps peer review need to stamp out and exclude badly designed studies to force better design. Do you have an opinion on this?
I do. Peer review. So what I'm gonna try to do is be even toned and measured in my response, because I do have strong opinions. So peer review, I think, is highly overrated. I mean, I think, okay, so peer review versus just, randomly publishing things without any peer review. I think peer review can be useful, but so a lot of my research in the psychopharmacology area there are studies that should have been nowhere near seeing the light of day that are published with regularity. So and part of the problem now is you get to, well, let's say this. You don't necessarily get to pick your own reviewers, but you get to have a say in it. So, when I submit papers and when many other researchers submit papers, part of the submission process is you list suggested reviewers. And obviously, if you have any sense of political savvy whatsoever, you're going to select people who are, if not personal friends, at least people who are friendly to your theoretical background and your ideas. So, the peer review process can be very political. I've certainly received peer reviews back where I go, your comments basically are not germane to my manuscript. You seem to just not like this area of research. So, and I've also, I've seen some peer reviews that aren't very good, frankly, and I've seen peer reviews that miss some blatantly obvious issues. So, as a reviewer, oftentimes, depending on the journal, sometimes you're able to see other peer review comments, and sometimes it's very clear that peer reviewers barely read a manuscript if they read it at all. But I will say the peer review system, okay, sorry, this is going to be a longer answer than you were looking for, but the peer review system is volunteer based. One time I was paid for a peer review. It was one of the best days of my life. I couldn't believe it. That was a one-off deal. I've reviewed hundreds of articles. I've been paid once, which is probably more than most people. So it's volunteer, and so you're sort of doing it out of the goodness of your heart. And the publishers love this system, right? Researchers submit their work that they spent, an ungodly amount of hours producing. The peer reviewers work for free. Then the publishers take the copyright and publish it at a profit. So the whole model essentially relies on the good work of researchers to both conduct the studies and review studies. And in the case of peer review, like what's in it for the reviewers to do a better job? I think the whole system is I'm not sure exactly how we would improve the system. I mean, perhaps, I don't know if people's paid work would be better than their volunteer work, but I think it might be, might be worth something.
I can pass the microphone now back to Kim, since we don't have any other questions pending. Let me see if I can. Hey, Kim, can you talk?
Yes. So lucky me. Glenn, I wanted to ask you. I've recently done and writing up the manuscript for a multi-level meta-analysis, and so it so happens to be that recently also normal sort of old-style meta-analysis came out on the same topic.
Oh, okay.
But with really different results. And I was wondering, I can see how this is going to be an issue for reviewers. And I was wondering if there's anything in the methodology of maybe those multi-level meta-analysis that, I don't know, kind of like, because some of the results are really not the way that I expected them to be. And I was wondering, like, sometimes with multi-level models in general, you have more parameters to estimate. So that takes away a little bit of the power as well. And I was just wondering if you have any experience or kind of ideas to share as to the differences between those sort of regular old school meta-analysis and multi-level meta-analysis. In sort of how they compare and,
I think this is a great question. So let me first of all just start off by asking you a question. So when you say multi-level, you don't mean network meta-analysis. You mean multi-level, right?
Yes.
Okay, good. So I will, after I'm done addressing your question, I will talk about network meta-analysis because that is also kind of a very trendy thing these days that I've got some problems with. But okay, so multi-level meta-analysis, I can tell you right off the bat that you are more of an expert than me. So, but I think what there is very little to my knowledge, and you may know more than me, but your question suggests you're not sure either. I would really be interested to know, like, is there systematic research that takes, compares meta-analyses doing, so, old, I'm not sure what the term is, old school, normal, I'm not sure, right? So meta-analysis in terms of, how I guess I've sort of fall into that crowd, versus multi-level, and compares like what happens, because obviously that's pretty important, right? So, I didn't really touch on statistical methodology today, but I think you bring up a really good point. And my concern would be, if this doesn't get addressed, how often is this going to happen, right? Where you have two conflicting methodologies that generate significantly different results. And in the case of meta-analysis, we're doing this for the sake of precision and statistical accuracy. So it's kind of strange, that you'd have these substantially different results, which, what's the whole point of a meta-analysis if we're going to generate different results depending on, we would assume that these should generate pretty similar results, but I'm certainly not expert enough in kind of like the underlying statistical methodology, comparing the two to really give you guidance on that. But my thought is that, like, this would make an excellent, if anything, case for your paper to say, well, look at these different methodologies and look at the different results they generate, and that in itself is worthy of discussion, because that's really important.
Yes, yeah, I agree. And actually the overall effects aren't that much different, but it's mostly the moderation analysis where things seem to be going like a different direction.
Can you say more? Like, I'm curious, when you say like a different direction, like how is yours different than, kind of the one you're comparing to?
Yeah, so you probably know that my research is in feedback interventions, and so recently Lambert did a meta-analysis on feedback studies that just came out, and so our meta-analysis is also on feedback interventions. But I think one big difference is that we were more inclusive, but we also included non-randomized studies, but did code for that. So I was happy that you're saying that that's allowed. So
I think it's fine. Yeah.
Sure. And there are actually no differences in effect size if we took out the non-randomized studies. So, but in feedback research, we tend to usually find bigger effects for non-on-track cases, although it's not true for all studies. And that's what Lambert indeed found. However, in our meta-analysis, we found the exact same effect size for not-on-track cases as for the full samples. Yeah.
That's interesting. Okay.
It is. Now, there obviously is like a subset of studies that report on not-on-track cases. So I looked at whether there would be differences that really sort of strike are clearly like different, or like is the overall effect in these studies maybe smaller, so that it kind of like becomes like a subsample problem. But that also doesn't seem to be the case. Yeah, so in that sense, it's kind of against what I had expected. But I should, I think it might actually be that we are more inclusive and therefore also including other studies. And not all studies have found these not-on-track effects, so that could be part of it.
Well, so here's a question that I think like this would examine, whether this is an artifact of statistical methodology to some extent. Like, have you run an analysis where you only include the exact same studies that were in the Lambert meta-analysis and see, you know what I mean? So you're basically comparing the exact same studies because I would think that would, otherwise it seems if you're including different studies coming up with different results, like I'm not sure that that's really an artifact of the analysis, but if you include only the exact same studies, then if your results are much different, then maybe we have like an artifact of statistical methodology as opposed to included studies. Does that make sense?
Yeah, that makes sense. I'll give it a try and then do that. It might be tough because some of the ones that he included don't have control groups. But I'll have a look. Well, the way that this is very detailed for most people, I think it will not be interesting. But the way he ran his studies is that over time he started to use a historical cohort as a control group when the center no longer wanted to not provide feedback because they found it unethical. So the later studies that found some of the larger effects do not have an actual control group, but they have, and they share the control cohort. So that makes it even more complex. So what I did I piled all of them together. So there's one big control group and one big intervention group that includes all the feedback studies. So that way the information isn't used twice.
Okay.
But I don't think you did that. So
I can see how, I can see, I mean, just from what we're describing here, like I can, it's like I can see how some of these, how you'd be generating different results because there's, kind of different choices as to how control groups and how different analyses are done. So it's like, to me, that doesn't sound like necessarily a problem. It's just sort of like different choices as to how to treat data, which sound reasonable on your end.
Okay, well, but I'll definitely try to run only those studies that he selected and at least see if we get closer to what he found.
Yeah, I mean, you can see my email address on the screen. Like, I'd be happy to correspond with you more about this. I think this is really interesting.
Great. Okay, thank you.
Thanks, Kim.
I'm loving how we're creating a SPR conference-like environment here with all the back and forth. And I actually have another person here, Chris Evans, who would like to chip in. So I'm going to pass the microphone to Chris. Chris, can you talk?
Hi, can you hear me?
Yes.
I can.
Yeah. Okay, great. Thanks very much. It's lovely to hear an expert talking about his or her topic in this way. I liked what you said about peer reviewing because it was so cynical and so nihilistic, and I completely agree. But isn't there a danger we could almost say the same thing about meta-analysis, that it creates a sort of, if it's the way it's often done, is to say, here is the right answer. And I heard you earlier on being very careful to say that that's terrible, that's a misunderstanding. Though I did hear you answering Kim, sort of saying, well, if meta-analysis doesn't give us the same answer, something's gone badly wrong. And I think there's a great problem that we're now in a field where actually it's becoming very difficult to do research that is not randomized controlled trials, and it's getting very difficult to draw conclusions that don't come out of meta-analyses of randomized controlled trials. And my great problem is that for pharmacological RCTs, you can remove to a very large extent placebo effect, allegiance effect, everything by having a placebo that can't be distinguished. My view is that in almost all psychosocial interventions, this is impossible. So in a way, I sort of agree with your medical meta-analyst expert, I've forgotten his name now, but I'd almost say it the other way around, that psychosocial intervention meta-analyses of randomized trials are doomed to be garbage in, garbage out, because you can never purge out the fact that all the participants know which they're getting.
Okay, so I mean, I appreciate there were lots of comments in there that I thought were quite interesting. I agreed with a great deal of them. So, but your end point was kind of garbage in, garbage out on psychotherapy intervention or psychotherapy comparative studies because of a lack of participant blinding. Just to make sure I got that correct.
Yeah. I
mean, I guess I'm not sure. to me, I'm more concerned with, rater blinding in those trials, but I understand that participants are often, some of the raters in the studies, right? So, I think that conceptually psychotherapy, in the real world, people are obviously not blinded to whether they're getting a particular form of therapy. So, to me, I think there are a lot of, you mentioned peer review and, the way studies are designed. There are a lot of things that I think are problematic. And I guess for me, I don't consider that to be, one of the, at least in my view, I don't consider that to be one of the bigger problems. I do think, there are a lot of meta-analyses that don't control for a lot of variables that are, a little bit of garbage in, garbage out, or at least, the studies might be fine if you controlled for some of the variables, but if you don't, you've got problems. So to me, though, a lack of participant blinding, like I conceptually, that's just part of psychotherapy. I don't see that as necessarily a fatal problem, but I'd be interested in, if you have more comments on that, I'm interested in hearing them.
I suppose my view is that the FDA or the European Medical, I always get the term wrong, simply wouldn't allow a randomized control trial of a medication if it couldn't be participant blinded, because we know that for most endpoints, including mortality endpoints, placebo effect is massive. Mm-hmm. And yet, just because we can't do blinding in psychotherapy, I think we're caught up saying, oh, because we can't do participant blinding, it's not going to worry me. Sort of to quote you back to yourself. And I think,
okay.
Wait a minute, it ought to worry us.
Okay.
Do you see my?
I get what you're saying. I get what you're saying. I think part of it becomes, sort of like, I sort of view like the placebo effect is a huge part of psychotherapy. And so I think like one can't conceptually get rid of that. And, so I think, attempts to control for the placebo effect in therapy by having these, as I mentioned earlier, under non-bona fide therapies, having these therapies delivered where the therapists know that it's not a real intervention, like I don't think those conceptually really make sense. I can understand, trying to control for a placebo effect, but I just don't think it works in psychotherapy very well. Mm-hmm. So I think, kind of embracing that, a large part of psychotherapy may in fact, or forget may in fact, is definitely a placebo effect. Mm-hmm. Sure. I think in the case of, in the case of medicine, we're probably dealing with products which in many cases are much more dangerous to take than psychotherapy. And, one might use, you could sort of benchmark psychotherapy by comparing it to medicines, right? So if we have something that, does outperform a placebo, with a few asterisks after it, in the case of like antidepressant medication, you could benchmark psychotherapy by comparing it to medication, right? If it's been found to be better than the placebo, then compare psychotherapy to it. And that's kind of a, an indirect control for a placebo effect. I'll admit it's not ideal.
Network analysis, network meta-analysis, isn't it?
Oh boy. God, let me go. Okay, so network meta-analysis, I think
I was being naughty, Glenn.
Okay.
I was being naughty.
Okay, yeah, I'm not a huge fan of network meta-analysis.
I gather.
Comparing, basically network meta-analysis, for those who aren't familiar, like does indirect comparisons. So if psychotherapy, was compared with a placebo in a study, and we could compare how psychodynamic therapy compares to a placebo by comparing it to other studies that compared another therapy to a placebo. These strange indirect paths that don't control for dozens of potential confounds. And they're huge. Network meta-analysis is like the sexy analysis these days, but rant over. I'll not talk about it anymore.
It's very politically topical at the moment in the UK. I don't know if people know that NICE, our National Institute for Clinical Excellence, actually it's not what it's called now, but everyone still calls it NICE, has, I think for the first time, the latest depression guidelines have had to be taken back because the network meta-analysis that they were using has been criticized as not following their own rules and various other things. So if anyone thinks this is sort of no great political importance, certainly in the UK at the moment, it's massively, massively important. Thanks from my point of view, thank you very much, Glenn.
Thank you.
Most impressive and entertaining. Thank you.
Thanks, Chris.
Thank you so much, Chris. And actually, we don't have any further questions, Glenn. So I
Okay.
don't know if you want to conclude with any final remarks before we close this off.
Boy, I'm not sure what else I would say. I suppose, just without being super redundant, I hope that, at the very least, people will carefully consider a variety of potential confounding variables, moderator variables in, when looking at clinical trials of psychotherapy. There are different, variables to control for in medication research that are very important and often overlooked. And just to be, I think it's okay to be a little skeptical and to, be sure that these things are accounted for, because otherwise I think we can have some problems in the way that we understand psychotherapy's effects. I thank you, Alex, for putting this together, and I'm really appreciative of the nice questions and discussion, and I would be more than happy to, continue to communicate with people about this in the future.